All right, so what is a PE, Mr. La Rosa?
You want me to read? It's a collection of particulate matter, solid, liquid, and or air that enters venous circulation and lodges in the pulmonary vessels.
All right, thank you, sir. So a PE isn't always a blood clot. It can be other substances. It could be a fat embolus. It could also be air. It could be from a piece of a central line, for instance, or any other solid matter. Right? But for the purpose of tonight's discussion, we're only discussing a pulmonary embolus caused by a blood clot. Blood clots are formed by the presence of the varicose triad. If you remember that from chapter 36, varicose triad are, you still remember the three? Mr. Basang. What were the varicose triad, sir?
Where is it? I don't see it. No, I don't remember it, sorry.
Okay, so they are hypercoagulability. Next is venous stasis. You can see my board, right? Yeah.
It's open, Professor.
Can you see the whiteboard?
Yes.
Okay, all right. So we have the presence of these three forms a clot. So if you have any one of these three conditions, you have a clot. Endothelial injury is any injury to the vessel. So similar for a check, you get a paper cut, you undergo surgery, you get trauma. So that is endothelial injury. So you have an injury to the vessel. Every injured vessel, of course, will release tissue factor, which will now trigger your clotting cascade. And then we have venous stasis. This is any condition that results in blood pooling. So for instance, we just concluded embolic stroke. So AFib, for instance, will cause venous stasis inside the heart. We also have obesity, for instance. So obesity will cause poor venous return because of the weight imposed on the vessel. So there'll be a lot of resistance from venous blood flow. And we also have immobility. So that would be any immobilized person. In the case of hypercoagulability, we have pregnancy. What else? Taking oral contraceptive pills, for instance. You have cancer. Several other examples. So these are all on chapter 36. So regardless though, you have a summary here of a few of them on your textbook. Here we have prolonged immobility. So on the test question on the next exam, you won't see prolonged immobility on the choice, okay? So you'll see actual patients with prolonged immobility, say a mechanically ventilated patient, a patient with paraplegia, for instance. Okay, so let's say somebody who had a high cervical injury, for instance, so that's a quadriplegic. Central venous catheters, we discussed this in third semester also, chapter 13. Particularly PICC lines. You remember PICC lines are notorious for blood clots. Surgery because of endothelial injury. I mentioned obesity, And then advancing age, again, poor circulation, poor venous circulation in advancing age. Conditions that increase blood clotting, I mentioned cancer. Um, did we discuss DIC yet? You did discuss DIC in OB, right? Yes?
And we discussed it with you too,
When was that?
in the complications of cancer.
Oh, yeah, okay. Yeah, oncologic emergency, okay. And then history of thromboembolism, meaning if you had a blood clot before, then you're prone to another one. So here are more. All of these fall under one or more of the three varicose triad. So those are the three conditions that result in the formation of a blood clot. And as already mentioned by Mr. La Rosa, these are the other causes of pulmonary embolus besides a clot. So therefore, it's easier to prevent a blood clot rather than dealing with treating it. PE has a high mortality. It's probably accounting for 80% of those people you find dead in the bedroom. I mean, in the hospital bed. So let's say you're on a non-telemetry floor, you walk into the patient's room and you find them dead. Chances are 80% of the time, the cause of that death was a PE. It could have been preventable. Most of the time, it's preventable with careful assessment of the patient. Most of these start as a DVT. So our prevention here will be the same as what was mentioned in chapter 36. If you look at chart 32-1, it's almost identical as in chapter 36 under prevention of DVT. Okay, so let's just read along this. Let's just skim through this because this is a redundant chart from chapter 36. So just keep the patient moving, just keep blood flowing, avoid conditions that will lead to one or more of the varicose triad, meaning if the patient has immobility and it's impossible to ambulate them, at least put stockings on, anti-embolic stockings, or let's say perform passive range of motion if they can't do it themselves. Leg exercises. Ideally, ambulation is preferred, but some patients, like the ones I mentioned, who are um, quadriplegics, for instance, or paraplegics, or those who are intubated, unconscious, or have severe limitations. Okay, so let's say they're 900 pounds, for instance. So most of those patients can't ambulate anymore, or ambulation is very difficult. When we elevate the legs to promote venous return, just make sure the pillow is not under the knee, okay? It's only on the calf area. So because we have arteries and veins right under the knee, the popliteal vessels are there, so don't impede circulation there. I mean, you can read, right? This one, refrain from massaging legs. No crossing. Most of us have this habit automatically. Like when we're on the couch, for instance, some of us like to cross our legs. That's not good for circulation. If needed, the patient's risk for DVT is high enough. Let's say they score 2 or more on the DVT risk assessment tool, then the doctor will prescribe a anticoagulant. So most of the times, most of the drugs we use are, of course, unfractionated heparin, 5,000 units once a day or up to every 8 hours, depending again on the patient's risk. Or the more commonly used are the low molecular weight heparins, right? The enoxaparin. Try to avoid these activities here. Stop smoking. This one, of course, could be a very good select all apply question. And this was already mentioned in chapter 36 also. If the patient has a contraindication, for instance, for anticoagulants, let's say they have hemorrhagic stroke history, so therefore this contraindication to anticoagulants, or they have a history of a bleeding peptic ulcer, for instance, wherein anticoagulants are high risk to them, they will be given IVC filters. If you remember, this was again in chapter 36. This is a device surgically implanted in the inferior vena cava, which will, of course, catch, it's a filter, so it will catch any blood clots coming from the inferior vena cava. There is no SVC filter. There's only an IVC filter. So therefore, this is not 100%, because what if the blood clot forms above the superior vena cava? Right? All right, so in a PE, the problem here is this is a mismatch between ventilation and perfusion. If we go back to the illustration up here, this will explain the problem in a PE. So blood goes to the lungs, but then it does not get blood it does not get oxygen when it comes back to the heart. Again, blood goes from the right ventricle into the left and right pulmonary arteries. They get there, but because one or more pulmonary arteries are blocked, they cannot get oxygen. So gas exchange is impaired. So it's like the blood went there, but then because one or more pulmonary arteries are blocked, so therefore not all of the blood that returned to the left side were carrying we're carrying oxygen. So therefore we have a mismatch. We have good perfusion, but then not all of those hemoglobin got blood in return. Are you with me so far? So this is a ventilation perfusion mismatch here. All right, so this is the problem in the PE. So the resulting problem really is a hypoxemia. And of course, depending on the number and size of the blood clots present in the pulmonary arteries, that will also increase pulmonary pressure, meaning the patient will develop pulmonary hypertension here in such a short period of time, putting a great stress or workload on the right side of the heart, which is in charge of pumping blood to the lungs, right? So there are three categories here. Let's do the key features first. The features in PE is related to pulmonary hypertension as well as the hypoxemia. And then because of the increased pressure now in the pulmonary circulation, the patient can develop pulmonary edema as well. So the classic symptoms of a PE, however, some PEs, again, it really depends on the category. We have three categories of PE, but classic symptoms are the following. So the dyspnea here is usually sudden. There's acute onset dyspnea, which is unprovoked, meaning there is no reason, there's no identifiable reason. The patient just suddenly develops shortness of breath, accompanied by sharp stabbing pain, and the patient has this feeling of impending doom here. These are all related to the sympathetic nervous system response in response to the hypoxia or the hypoxemia sense as blood gets to the kidneys. There is a cough. The cough and the hemoptysis here, these are related to the pulmonary edema that results in a PE. And here are the rest of your signs. These are again the classic, okay? What's on the exam though will be specific to the category. So let's look at the three categories next. But there's still some information here. Okay, I mentioned the pulmonary hypertension that results. So this obstruction, which is what's happening in a PE, is not really an infarction. If you think about it, had this blood clot been in a coronary artery, we would have called it acute coronary syndrome, either unstable angina or STEMI or a ST elevation MI. Had this blood clot lodged in a cerebral artery, we would have called it either a TIA or a stroke, right? How come we did not call it a pulmonary infarction in the case of a pulmonary embolus? Because this is what happened. As Mr. La Rosa said, there is a formation of a blood clot, or it could be a fat embolus, air, or foreign body, etc. How come this is not called pulmonary infarction? Because it's really the same thing. There's a blood clot obstructing one or more pulmonary arteries. How come the term is not called pulmonary infarction? Any comments?
Is there any death of tissue in the lungs?
Say again, Chris.
Does it have to do with death of any tissue in the lungs?
Yeah, how come it doesn't happen? Because one or more pulmonary arteries are blocked here. How come they don't die? There is no infarction here. There is only lack of gas exchange. Okay, there's a ventilation perfusion mismatch. The patient's breathing fine, but then the gas exchange is not happening because there is no blood flow to one or more parts of the lung, because there's an obstruction by one or more blood clots. How come it's not called an infarction? And how come the lungs do not die? Anybody? Because if you think about it, that's what's supposed to happen, right? Betsy?
Could it become,
Yeah. Hello?
could it be because usually these embolus are very small and then they get absorbed?
Well, eventually, but well, while the PE is there though, the blood clot stays. That's why we give them anticoagulants, okay, to prevent that clot from getting bigger. How come the lungs do not die? How come there's no infarction that results? Why is this only called a pulmonary embolism, not pulmonary infarction?
Is it because of the amount of vessels that we have in the lungs?
All right, very good. There is dual circulation in the lungs. The lungs are not dependent on the pulmonary arteries. In fact, they do not perfuse via the pulmonary arteries. The pulmonary arteries are only getting oxygen for the rest of the body. The lungs do not get oxygen via the pulmonary arteries. Maybe some, okay, there are some collateral circulation there if you look at the anatomy, but really majority of the pulmonary blood flow, the pulmonary perfusion, is via the bronchial arteries, which is a branch out of the aorta. Does that make sense?
Yes.
All right, so just like the heart, for instance, the blood inside the heart, it isn't perfusing the heart, right? The blood has to exit the heart first, and then during diastole, it fills the coronary arteries. So kind of the same way, as the blood leaves the left ventricle, after the three branches, you have the left and right carotids and the subclavian. Along the thoracic branch of the aorta, there is the bronchial artery there that branches out. That artery supplies the left and right lungs. Okay, so that's why it's almost impossible to infarct the lungs. So that's why you almost never hear of a pulmonary infarction. All right, labs. There are two ways to do this. Labs, though, isn't going to make a diagnosis. Lab findings will only aid in the diagnosis of a PE. The diagnostic study is really done with a pulmonary angiography. So we need a CAT scan in order to literally find the blood clot. Right, so this is the gold standard. Granting the patient doesn't have any allergy to dye or does not have kidney injury, for instance, we can send the patient for a CAT scan. So pulmonary CT angio, and then we can see the blood clot. So they put the dye in, they take a picture, whichever part of the lung, of the pulmonary artery specifically, do not receive the dye, there's the obstruction, right? So the dye stops at wherever the blood clots or blood clots are. If the patient, however, has contraindications for the CT angio, namely allergies or kidney signs of kidney injury, then we cannot do the CT angio. There is an alternative. We have a VQ or ventilation perfusion scan. This is done in the nuclear medicine department. So instead of giving you a IV dye, you are going to be given a radioactive gas. So you'll be asked to inhale gas, and then they take a picture. And then whichever part of the lung did not diffuse, meaning whichever parts of the lung the radioactive dye or gas did not diffuse into, then there's the blood clot. Okay, so two ways to make a diagnosis. However, to get this started, let's say because all these symptoms here, if you look at chart 32-2, this could be anything. Meaning, if we cover that pulmonary embolism and then just watch these, do these look familiar? Did we see this in heart failure? Did we see this in, well, we haven't done respiratory failure yet, but this was also in pneumonia, right? Some of this was, well, parts of it was in COPD exacerbation. So this could be anything. A patient with MI, which we haven't talked about yet, also has these features. Okay, they also have chest pain, they have dyspnea, they have the apprehension, there's no tachypnea, there's crackles, especially if the patient having an MI already developed heart failure. So these are not specific to PE. So therefore, when a patient presents with these, doctor can't just send them to the CT, right away, because they need to justify, an expensive test. Why did you order that? What was your initial proof that the patient could have a PE? So the lab test may come first. So the patient will draw blood. So these are the blood tests that will be drawn. Okay, so the doctor needs to isolate the other causes. Namely, we know about chapter 35 already. We know that BNP is specific to heart failure because these are the peptides that were released by the stretched ventricles. So B-type natriuretic peptides are specific to heart failure. And then troponin, of course, is specific cardiac enzymes in an MI, myocardial infarction. And finally, a D-dimer. So a D-dimer is a fibrin split product. If you remember, this was also used in DVT to help aid in the diagnosis of a DVT in chapter 36. So, so we will draw all of these so that the doctor can make a decision, what are we dealing with here? So the negative, if the troponin is negative, BNP is negative, the D-dimer is positive, then that's now pointing toward a blood clot. Okay, it could be a DVT or a PE, but based on the patient's clinical symptoms, they're presenting with these features in chart 32-2, and then you have an elevated D-dimer, which is again a fibrin split product. If you forgot already what a fibrin split product is, this is the end, what's left of a blood clot when the body dissolves it. So at the end of fibrinolysis, which is a naturally occurring process after a blood clot is formed, one of the um, leftover materials after you break down fibrin is D-dimer. Right? So it's a fibrin split product. So the only explanation is if you have a lot of D-dimer, that means you had a lot of blood clots that were dissolved by the body. Any questions so far? Okay, so we did the signs and symptoms, and then we did the diagnostic testing, and now we let's do our interventions. Here's a warning. So if you have any unexplained sudden onset of dyspnea and chest pain, so consider a PE. So you notify rapid response right away just to get the ball rolling, because we have a short window here depending on the size and number of blood clots that have ended up in the pulmonary arteries. If you're wrong, so what? At least you're sure that the patient did not want for medical care. All right, so they received the care that they should receive. We seldom do surgery for PEs. The management here is usually because most of the cases are submassive PE. So the major treatment here is the administration of anticoagulants. So we summarized everything here in chart 32-3, but we will go specific after this. So generally speaking, any patient with a PE receives oxygen. We start with nasal cannula, and if it doesn't raise the patient's AO2 above 92, then we switch to a mask and so on. We go to a rebreather mask first, and then we go to a non-rebreather. After that, if still unsuccessful, then the patient will have to be intubated. We'll discuss intubation next week. Reassure the patient, because again, the patient has a feeling of impending doom here. The patient is scared to death. So do not leave the patient, provide reassurance, because anxiety will not help here. More anxious this patient gets, the dyspnea will increase, and we don't need that. Put the patient sitting upright. We put on telemetry because this will trigger some dysrhythmias, because remember, the patient develops pulmonary hypertension here. So there will be increased workload on the right side of the heart. This may trigger AFib or any other dysrhythmia. If the patient doesn't have a venous access already, so we start an IV access. And then your routine respiratory assessments. So the same thing as with any other respiratory patient. So we check any of these conditions. If you, no, we haven't talked about chest trauma yet, and we haven't talked about dysrhythmias yet. Okay, the patient, one of the causes of, and we haven't talked about shock. One of the causes of obstructive shock is a tension pneumothorax. Now, it can result from a PE. So once the pulmonary hypertension goes so high, it may cause a spontaneous rupture of certain parts of the lung, resulting in a pneumothorax. And that pneumothorax may be a tension type. So that's why that would explain why we would check for the alignment of the trachea, because the deviation of the trachea will indicate that there is now buildup of positive pressure in one or more lungs, which will now move the mediastinum. I'll explain all that later under chest trauma, okay? So same thing here, check for jugular vein distension. This is related to this tracheal deviation here, which is resulting from a tension pneumothorax. Then make sure the blood is drawn for all of these that we indicated earlier under the laboratory findings. So we will draw all of these. We will include now bleeding time because we anticipate the patient receiving anticoagulants, or in severe cases, if this patient has a massive PE, they may receive a thrombolytic. They may receive alteplase. Okay, and then we prepare for giving anticoagulants, and of course, related to that, we will watch for bleeding and institute bleeding precautions. So the treatment here, like I mentioned earlier, will depend on the diagnosis. Table 32-1 gives you the 3 categories of PE. So we have the most serious, which is massive. We have submassive, which is the most common, and then we have low risk PE. When we talk about massive PE, look at the mortality, 65%. These patients either have large size clots or large number of clots. Look at this. Why would there be severe hypotension here? So imagine large clots clogging large portions of the pulmonary artery. So what will happen to your forward flow here, even if it only affects one lung? So let's say it's on the left lung. So the left pulmonary artery here, one or more major parts of the pulmonary artery are blocked. So what happens to the forward flow of blood from the left pulmonary artery? Is it the same as on the right side?
Is it blocked as well?
Yeah. Well, I just said the PE is on the left. All right, so we have large size, large number, multiple number of blood clots that have lodged in one or more parts of the left pulmonary artery. So imagine the amount of forward flow on the left side, meaning if you trace the direction of blood, so blood returns from the superior and the inferior vena cava, right? Let's go back to, all right. So let's say this is your, so this is the right side, right ventricle, left ventricle. So this is your pulmonary trunk, and this is going to the right, and this one is on the left. Okay, so you have your lungs here. So let's say it's the left. Okay, so one or more of the branches here have blood clots. Okay, large and multiple enough to obstruct blood flow. So these are now going to your alveoli. So whereas it's clear over here, there's no blood clots that ended up on the right side. So what happens to the forward flow here? Do you have normal blood flow in the left lung?
No.
No. So there is now increased pulmonary hypertension here. So there is increased pulmonary hypertension resulting in decreased forward flow. So if you only have the right lung giving you normal venous return to the left side, this is the left atrium. So there's so much, the afterload here is so high that the right side can only pump blood to the right side. It's having difficulty pumping blood here. So what happens to the forward flow? Do you have enough blood getting back to the left atrium? Yeah or no? Yay or nay?
Would it be no?
No. So the normal venous return is only coming from the right side. So that's about half only of the preload that's returning to the left side, because there's not enough blood getting to the left side here, because most of it will now be left in the right ventricle. So therefore, will there be congestion in the right ventricle as well as a result, because it can only pump blood here and this can only receive so much blood, and then therefore it can only return so much blood to the left also. So our problem is right here. So there is decreased forward flow here, resulting in decreased venous return on the left side. Okay, so therefore, what will happen to your cardiac output here?
Decreases.
Okay, it will also decrease. So that explains all your symptoms here. If you look at the massive PE, look at the symptoms. The patient even goes into shock. Okay, the blood pressure could be severely low here. The blood pressure here could reach less than 80 or even 80. That's already shock level blood pressure. That's not enough pressure to perfuse the vital organs, or so much more the peripheral organs. Okay, the patient here could go into cardiac arrest, not to mention right-sided heart failure as well, because that will put so much workload on the right side, so much congestion that could develop fatal dysrhythmias, and that dysrhythmia may lead to cardiac arrest. And of course, this patient will be in severe respiratory distress here. That's why your interventions will be, if this patient goes into arrest, then CPR, ACLS, and we will need to manage this patient as with any other patient that's in cardiac arrest. So full ACLS if needed. Like I mentioned earlier, the patient will be given fibrinolytic therapy. It'll be a different dose though, not the same as in stroke wherein it was 0.9 milligram per kilogram. This will be a little bit lower. I'm not really sure what the standard is for a PE. So here's the TPA. That's alteplase. And then, of course, before all this, the patient will be given heparin as well. I know you may say it's dangerous because the patient will be giving fibrinolytic therapy at the same time. Alteplase and heparin isn't good, but we need this heparin here to keep those clots stable, meaning that the clots must stay the same size. We don't want them getting bigger, because you know how clots are. Once a clot is formed, it'll only get bigger and bigger and bigger, because once platelets circulate and then they find an existing clot, they will stick there, right? They will make the clot bigger because they will be activated as well. So once a set of platelets are activated, it will activate more and more platelets. It becomes a vicious cycle. In the case of a submassive PE, so the number and size of the blood clots here are smaller than those of a massive. So look at the blood pressure. The patient will have normal blood pressure. However, there will still be the same pulmonary hypertension, leading to greater right side workload, right ventricular workload. So you'll see right ventricular dysfunction, dilation. Again, there's congestion there now. That may result in these EKG changes here. And to a certain extent, of course, that is now stretching. There's now stretching involved here of the ventricles involved. So it will cause BNP elevation here. Treatment. At least in my experience, I've not seen any of my submassive PE patients receive thrombolytic therapy. So it's not worth it. I mean, you understood from stroke, the danger of alteplase. But this is the doctor's call. Okay, so of course, if in this case here, they have no choice here because the patient is hemodynamically unstable. So TPA has to be administered in massive PE. Not so in submassive. As long as the patient stays like this, meaning there's adequate cardiac output, there's adequate perfusion to the vital organs, it's not worth it to give thrombolytics. So our usual treatment here are our heparin infusion. So that's unfractionated heparin in a infusion. So that's a continuous drip. Or once the clots are determined stable, then the doctor may switch to these low molecular weight heparins here. Or this one, which is a direct thrombin inhibitor. We'll discuss the different anticoagulants shortly. And then low risk PE, these are the smallest population. Not all of these are even admitted to the hospital. So once a diagnosis is made and the doctor only saw a tiny bitty clot, they're usually sent home on low molecular weight heparin, or they're given a novel oral anticoagulant like Xarelto, for instance. Because here there's patient hardly has any symptoms. So the patient will have normal blood pressure, so normal hemodynamics, no right ventricular problem because there is no problem with forward flow here. There's no significant decrease in forward flow. That's why you have good cardiac output. And then there's no stretching involved, so no negative PNP, negative troponins. Right, so definitely no thrombolytics needed here. So the patient will just be given low molecular weight heparin and then sent home. This is ideal because if you remember in chapter 36, low molecular weight heparins are not monitored. They don't require PTT monitoring because the dose here is weight-based. I think it's 0.1 milligrams per kilogram. If I'm not, yeah, it should be in chapter 36. So the patient's dose here, it is weight-based. So therefore, regardless of what the PTT says, we cannot change, the doctor cannot change the dose because it's dictated by the pharmaceutical company that you give so much units per kilogram. So therefore, the dose doesn't change. So why bother checking the PTT? Does that make sense? Hello? Are you guys alive?
Yes.
Yes, makes sense.
All right, so forget about the test, okay? Because that's over. Let's just focus on, because you have a quiz next week, okay? Your scores tomorrow. What was that, Maria?
I was thinking about the previous quiz. Are you gonna consider the
Oh, yes, I will.
Thank you.
All right, so any question on the plan of care for each category? All righty. Yes, what was the question?
No, no question.
Okay. So again, the actions were summarized in chart 32-3. So the discussion is here in the next paragraph below the table. So we have oxygen here. Again, the choice of whether thrombolytic versus anticoagulant is based on the diagnosis, whether we're talking about massive, submassive, or low risk PE. So let's discuss now the drug therapy. Before we do this, let's watch and review our clotting cascade to explain how our medications work. Can you hear the audio on the video?
Yeah.
Yeah.
Okay, good.
Even under physiological conditions, a small tear can appear in the wall of a blood vessel. In order to prevent blood loss, platelets and coagulation factors, such as the pivotal factor 10, acting in a coordinated manner, close this wound. The platelets are responsible for a first sealing of the tear. Then,
all right. So this first part here, this is the, if you remember in chapter 36, this is the extrinsic pathway. Okay, so extrinsic pathway is shorter. It just takes, once the tissue factor is released by this injured vessel, so it will activate platelets as they circulate around this area. So platelets are activated and attracted, so they stick there and will stop the bleeding right away. However, it's not stable because nothing is holding those platelets together. They are loosely adhered.
A number of
So here they're just sticking there. So there's no glue, there's no thread holding them together. So if you notice, the last time you had a paper cut or any wound, it bled, right, initially, and then it stopped bleeding after a few seconds. However, you notice, especially if you touched it again, it starts bleeding again, right? So this is the illustration here. This is what's happening. So you had a temporary platelet plug, which again, nothing is holding it together, so it's not stable. So it can easily be dislodged.
coagulation factors are activated, leading to the formation of fibrin strands which stabilize the growing clot.
Okay, let's watch a different video. This is too short. It doesn't explain the. Okay, let's watch this one.
At the site of vessel injury, the first platelets arrive to start sealing the wound. Simultaneously, the coagulation cascade with its various coagulation factors is activated. This involves two pathways, the extrinsic and the intrinsic pathway. Extrinsic activation begins with now exposed molecules of the vessel wall, such as tissue factor, which forms a complex with factor 7. Finally leading to the activation of factor 10. This factor 10A is the point at which the extrinsic and the intrinsic pathways of the coagulation cascade meet.
Okay, so that was the end of the extrinsic pathway. So meanwhile, the construction of the more stable clot is also in the process here. So in the background, this is now happening. So this will now finish off the initial job. So the temporary plug there will now start to become permanent using the via the intrinsic pathway.
The intrinsic pathway consists of various coagulation factors activating each other in a chain reaction. At its end, a complex with an additional cofactor is formed. This complex now activates factor 10. Since the two pathways merge at the level of factor.
Okay, so we have anticoagulants, namely the novel oral anticoagulants. We call them 10A inhibitors. So this is the part wherein they inhibit it. So it's a common junction between extrinsic and intrinsic pathway, wherein it stops the clot formation right here. So it's a 10A inhibitor, so therefore it will prevent the activation of factor 10A. So therefore no clots will form because now the clotting cascade is interrupted right here. So as a result, there is no clot formation, which is what we want if a patient needs anticoagulation, of course.
10A. This factor has a pivotal role in the coagulation cascade. Further down the cascade, factor 10A in combination with 5A activates thrombin. And
all right, so this is where your heparin and your fondaparinux, which was Arixtra. So we have indirect thrombin inhibitors and we also have direct thrombin inhibitors. So the other anticoagulants stop the clotting right here. So they prevent the prothrombin from catalyzing thrombin. So they inhibit the formation of thrombin, which is now responsible for fibrin, which is now the strands that hold the clot. So this is the part where heparin works right here. So you have different drugs working in different parts of the coagulation cascade, which will help explain how they do what they do. All right.
And induces the so-called thrombin burst. One molecule of factor 10A can catalyze the formation of 1,000 molecules of thrombin. These large amounts of thrombin cause the further activation of platelets and the enhanced formation of fibrin. Fibrin then forms strands, making up the mesh that stabilizes the platelet plug in an arterial clot and holds together the red blood cells in a venous clot.
All right, so now you have, voila, you have a stable clot here. So you have a fibrin clot. So this will not be easily moved now because something is holding the whole operation together. So the platelets are not just loosely adhered, they are now tightly bound because of fibrin. So it is at this point, once a clot is formed, the body will now start dissolving this. So right after it's formed, the body starts fibrinolysis. So when your body breaks this down, then that fibrin holding there becomes D-dimer. And that is now your evidence of the presence of the blood clot. Question? All right, so let's continue with the drug therapy. So we have different options here. So the doctor usually uses unfractionated heparin, unless of course the patient develops HIT, which you discussed last semester in 201. Then we will switch to fondaparinux or, no, Arixtra is not a alternate. It was the argatroban, right? If you remember last semester, argatroban was the alternate for heparin if the patient develops HIT. We can either use this or low molecular weight heparin. Whichever one the doctor uses, the goal is always to prolong the bleeding time between 1.5 to 2.5 times the control or the normal. So we want to extend or to increase, prolong bleeding time. That way we have a less chance of forming a blood clot. You know already about alteplase. Okay, so usually what will happen is the patient will receive heparin. So we have heparin on board. The patient will be given a bolus dose. You've had bolus calculations on heparin as well as the infusion calculation in Math for Meds. So those will be 2 of the math questions on the next exam. Heparin is given first because as you saw on the animation for the clotting cascade, it will immediately inhibit thrombin formation. It is a thrombin inhibitor. Even if it's only an indirect thrombin inhibitor, it will inhibit thrombin. So no thrombin, no fibrin formation, no clot formation. It will do that immediately. So the second you give it, anticoagulation starts. However, we cannot keep this patient in the hospital forever. We have to eventually discharge this patient. Nobody gets discharged on heparin because this one is of course dangerous. We need blood monitoring every 6 hours. So we cannot discharge the patient on heparin infusion. Patient will have to be discharged on warfarin or these novel oral anticoagulants. Okay, so let's say that there's a contraindication for these drugs here. So the patient can't have them for, let's say it's a, I don't know, there's AFib, for instance, caused by a heart valve problem, so no. But since this is a PE, the recommendation for PE is warfarin. Okay, this is the most effective drug. Although again, if it's a low risk PE, then they can be discharged on rivaroxaban and the Eliquis, apixaban, etc. However, if it's a submassive or a massive PE, the preferred drug is warfarin. Now, warfarin is a vitamin K inhibitor. It does not, if you notice on the Clotting Cascade on the video animation you watched, there was no mention of vitamin K there. Vitamin K is needed to do what? If you remember in peds, why did you give vitamin K injections in newborns?
To stop the bleeding. And bleeding because of the coagulation factors. The liver is immature.
All right, so therefore, vitamin K is needed to form certain clotting factors. Not all of them. There are at least 4 vitamin K dependent clotting factors in the body. So warfarin will inhibit the formation of those 4 clotting factors. However, warfarin can only prevent future clotting factor formation once you start taking it. So therefore, we have to wait until the clotting factors already in the plasma, already circulating in the bloodstream, to be eliminated by the body. So that usually takes about 5 to 10 days. So that's why the patient will have to be on both heparin and warfarin together for about 3 to 5 days. All right. Sometimes it may take the whole 10. Some patients are very resistant to heparin or warfarin, resulting in a longer anticoagulation period. But for most people, it's about 5 days. So the patient will be on heparin and warfarin at the same time. And then meanwhile, we monitor PTT for heparin while it's infusing. And we monitor INR for warfarin. And we wait until the patient's INR is 2, at least 2. And then we can stop the heparin, and then we can send this patient home on warfarin only. And then from then on, we monitor warfarin once a week for however long the doctor prescribes the warfarin for the PE. Right, so read the rest here. Heparin is usually infused for about 5 days. And then meanwhile, the patient's also on warfarin. So we monitor both PTT and INR for this one until, again, our number here is 2. If you remember in chapter 36, the DBT, our INR there was 1.5. Okay, this is a PE, so it's 2. For a recurrent PE, meaning the patient had a PE before and then they had another one, it'll be considerably higher though. In those instances, the patient will have to be, the INR will have to be at least 3 or sometimes 3.5, depending on the doctor's preference. Okay, meaning obviously that just means you have a higher risk of a PE, so we need your INR, your bleeding time, to be way longer than most people. Here are your responsibilities. So giving heparin, regardless whether it's heparin, heparin sodium or low molecular weight heparin, it's heparin, so monitor and perform these nursing responsibilities here. This is for warfarin. It's a vitamin K antagonist. So these are your nursing responsibilities again, please include the antidotes. So here's protamine sulfate, and here's mifeton or vitamin K. Here are your restrictions. Now, I'd like to repeat that it's not like you can't eat these, okay? You can eat them, but just in moderation. Your textbook does not cover the specific amounts, so I'm not testing you on the amounts, okay, or on the number of servings, because it's not available in your med-surg text. And fibrinolytics, we already discussed alteplase under stroke. And for 32-5, these are now your PTT, PTINR numbers. Okay, so you'll be tested here. So I mentioned the, where's the INR? Okay, here. For INR, if the PE, I think I mentioned this earlier. So if the patient's PE is recurrent, we need a way higher INR here. Okay, so here again, the discussion on the antidotes. If the patient though has a really high INR, meaning it's over 12 or worse, vitamin K will not be your phytonadione or mephyton is vitamin K. It won't work anymore if your INR is way too high. So the antidote at that point will have to be fresh frozen plasma, right, which contains clotting factors. In severe cases of warfarin overdose. That sometimes happens if the patient, let's say, or the nurse did not monitor the warfarin at home, or maybe it's the patient that did not show up for their appointments, and then the patient ended up with a really high INR. Then they start bleeding, so when they're in the hospital, vitamin K won't stop the bleeding anymore, so they'll have to be given FFP now. Surgery, this was already mentioned again, chapter 36. So if the patient has any contraindication for anticoagulation, then they'll receive an IVC filter instead. Yeah, that's the reason right there. And then, or it could be surgically removed. So if the clots are big enough, too big to dissolve, too big for us to anticoagulate and wait for the body to dissolve it, is way too big, so the doctor will surgically remove it. The rest of the interventions here are already for massive PE, which we will not test on chapter 32. They will be tested under shock, which is now for the final exam. So the additional interventions here, IV fluid therapy and these vasopressors here, will be again discussed under shock. All right, because the patient in massive PE will develop what's called obstructive shock, which is in chapter 37. Again, this part here in chapter 32, under in addition, this part here, this will be discussed and tested under chapter 37, because this will be mentioned again in chapter 37, because like I said, massive PE will cause obstructive shock, which is discussed. It's actually written here. See chapter 37. So we will skip this part here for chapter 32. All right. And then the rest of your nursing interventions here are related to bleeding precautions. So you have here chart 32-6. Redundant. You've probably seen this already in chapter 36 under DVT, because we gave anticoagulants there also. Although in this part here, besides anticoagulants, the patient with massive PE will receive fibrinolytic therapy, or in stroke, for instance, they were given antiplatelets. But the interventions are the same, right? So here, when it says avoid trauma to rectal tissues, that would include no anal intercourse, all right? For anxiety, because again, the patient has high anxiety here in a PE, it's scary. They have a feeling of impending doom, and if needed, then give them chill pills or IV benzodiazepines. And that's it. And it's already 8:40, so I guess, oh, it is here, okay? Here, avoid anal intercourse. Please include the others, okay? So not really, like here, playing wind instruments, you know, the trombone, what else? Trumpets, sax. They're contraindicated, okay? Because they increase intracranial pressure and then may cause bleeding. And that's it. It appears we don't have time anymore because I need more than 10 minutes to do acute respiratory failure. So next week's quiz is very simple. It's only all about PE. Any questions?
No, sir.